Thanks very much. It's really a pleasure to be here, and I wanted to thank Max and his team for hosting this really important meeting, thanking the organizers, also UC and Martha, who did all the technical work to make this happen. And then I also wanted to do a shout out to Dr. Tandami and Dr. Lillian, who were kind enough to bring me to a site visit to BCPP yesterday. It was really terrific. I learned a lot, and we had a lot to talk about, so thank you very much. I'm presenting this today on behalf of my co-principal investigator for SEARCH, Dr. Moses Kamya, who's chief of medicine at Makerere University. He's worked in the AIDS epidemic ever since it first appeared in Uganda. So SEARCH stands for Sustainable East Africa Research for Community Health, and it is an ongoing HIV test and treat study of 320,000 persons in rural East Africa. It is sponsored by a multinational, multidisciplinary research consortium established in 2010, and our funders and stakeholders include PEPFAR and OGAC, NIH, WHO, UNAIDS, World Bank, Gilead, and importantly, the ministers of health of the two countries where it is being conducted in Uganda and in Kenya. So the hypothesis of SEARCH is that the implementation of a population-based universal HIV treatment in rural communities in East Africa will result in reduced HIV/TB infectious disease burden, lower maternal and infant mortality rates, and improved economic and education productivity compared to standard treatment. And treatment includes enhanced HIV testing, linkage, and retention in the context of ongoing multifocal prevention activities. So the aims of our study are to evaluate the effect of ART at any CD4 cell count delivered with enhanced testing, linkage, and streamlined care on 5-year HIV cumulative incidence, on overall community health, looking at mortality, AIDS, TB, vertical transmission, infant and child mortality, transmitted drug resistance, CD4 cell counts, and HIV RNA levels. Also to look at economic and educational outcomes, including workforce participation and agricultural output, healthcare utilization, i.e. the cascade of care. Of course, we're looking at costing, as all the studies are, and importantly, the qualitative studies, which are examining attitudes of community, patients, and providers. The SEARCH study also aims to build and evaluate a chronic disease model of care that intercalates HIV, diabetes, and hypertension as the first chronic care diseases to start with, all in one comprehensive care program. So this is a pair-matched community cluster randomized trial. As I mentioned, it's being conducted in rural communities in Uganda and Kenya. The key study elements are that we perform a baseline community household census. We determine HIV serostatus in all members. We also, in HIV positives, measure HIV RNA and CD4 at baseline, year 3, and year 5. As the other studies, we are integration of all activities into the government health system, and HIV diagnosis and treatment is embedded into a larger chronic disease model. Our intervention includes annual community-wide testing with additional testing for targeted populations in between the annual community testing, immediate ART at all CD4 cell counts, enhanced linkage and retention, and what we call streamlined HIV care. Our study includes 32 communities, each approximately 10,000 in size, for a total population in the study of 320,000. The upper right shows a schematic when we explain SEARCH, why we should do it, to people around, and what it shows is there's a green zone, yellow, orange, and red zone. And the arrows, the one that goes to the bottom, explains what we did first in the HIV epidemic. We would allow people to get very, very sick, and then we would rescue them from the red zone. The idea of the intervention arm in SEARCH is that we find people in the green zone, we treat people in the green zone, we keep them healthy. And when we look at the different dimensions of when that happens, not only is it potential to reduce HIV infections and other associated infections like tuberculosis, but also the cost, burden, and complexity to the healthcare system is much less. On the upper right-hand panel, you can see the sites for where SEARCH is being conducted. It's not at a very close level of granularity, but our sites in Kenya are in the Nyanza province surrounding Lake Victoria, and then we have sites in the eastern part of Uganda near Chororo and in Mbarara. So in contrast to doing household testing, in order to determine HIV status, our study does community health campaigns. And we have piloted this concept over the last 2.5 years. And just in brief, community health campaigns are multi-disease health campaigns designed to remove AIDS exceptionalism. They reflect the community health priorities. So when we designed these, we went to the community and said, besides HIV testing, what would you like to know about your health? And they said, oh, we want to know about diabetes. We're like, oh, we can do that. We want to know about hypertension. We said, oh, that's no problem. We can measure that. So we tailor these to the extent that resources permit what the community is interested. They're high throughput, rapid transit, and they provide on-site treatment. They're staffed by community workers. We have laptops, rapid data entry. We share all the information with the ART programs and the Ministry of Health, and we have linkage and NCDs to government health centers. So these are some pictures from the Uganda community health campaigns. You can see we use wedding tents for setup. We see about 1,000 persons a day, and the normal transit time is probably about 45 minutes, depending on if you have any diseases. When people come in, they check in, they get their vital signs done, we do a survey, the kids get measured, and then we do hypertension check for diabetes. Everything is done with finger prick. We collect blood for CD4 cell count. We use Havlir. We collect blood via finger prick to measure viral load, which is then transported to a central lab where we do standard PCR testing. For those, we actually do malaria treatment on site. We do the rapid malaria test and treat people who have malaria. And then we do deworming for kids, and we provide bed nets and also condoms at the end of the campaign. As I mentioned, we piloted this and we've published this work for those who are interested. We did the first pilot study in the Kachuroi parish in Uganda. And here, this was the estimated prevalence. We found HIV adults with prevalence of about 8%. About 12% had hypertension, which is really in line with what's emerging in Africa, and about 3% diabetes. And we've been talking about how we find people with higher CD4 cell counts. And in fact, we found people with very, very high CD4 cell counts in a community campaign approach, because we're identifying a lot of asymptomatic individuals. And when you do these campaigns, all sorts of things happen. Those of you working on the field, I'm sure we have many stories to share. But there's torrential rains and all sorts of things happen. But these really have been conducted in rain or shine. I wanted to share these data with you because this has been something that's been alluded to in our discussions already today. These are data that we presented at CROI. In preparation to start search, we in essence practiced all the components of search. So we practiced our community campaigns and we refined them. We also wanted to look at treatment of individuals who were asymptomatic with high CD4 cell counts. So in a rural government-run clinic, we offered people with high CD4 cell counts, some who were newly diagnosed, some who were already in clinic, antiretroviral therapy. And I wish I would have put some other data we had here. The first question, first of all, there was a really, really high uptake. Over 95% of the people we approached said, yes, we want therapy. And we asked them why. And they said things were really pretty intuitive. I want to stay healthy. I want to take care of my family. Those were really the two main reasons why people said that they wanted to have therapy. And that we delivered therapy through what we call a streamlined approach, which is the first intake was done by a physician. All the other visits were screening visits really done by the nurse and triage to a medical officer only as needed. So the transit time was 30 minutes, and that compared to about 300 minutes, which was the case in the regular clinics. We had excellent adherence, but we all know the limitations of asking patients about adherence. And what we were most excited to share at CROI was in this cohort of 200 people, our viral suppression rates were 97%. And there really was nothing special, nothing magical. We didn't give people money to come to clinic. This is in a rural area where people said, I want to take therapy. Everybody said essentially they wanted to take therapy. This is the viral suppression rates that we achieved. We've asked the staff there, what do you think made a difference? One of the things that came up, which is I'm very intrigued about countries that already have access to viral load, is the viral load feedback is huge to patients. They felt like when they got this, and in fact, the clinical officers felt that explaining viral load was easier than CD4 cell counts because it was something they could go towards, and it was almost celebratory when they got a viral load suppression measure. So we don't know why these results are the way they are. I'm just showing you the data we have. And so far in our larger third study, the first community we rolled out also is seeing similarly high viral suppression rates in asymptomatic individuals. We have economists working on our study, and in addition to costing studies, we're also very, very interested in looking at aspects of productivity. This is another pilot study we did in preparation for search, and I think that in the box here, and once again this is published work, is that in a cross-sectional study we found that individuals with CD4 cell counts greater than 500 work nearly 1 week per month more than those with lower CD4 cell counts, and as much as HIV-infected adults. And our economists are doing really interesting questions to patients, even how they choose to invest their money, or what equipment they buy for the farm, or what schools they send to their kids, really can be influenced in terms of how they view their life and expectancy with access to therapy. I won't go through this, but we're, like the other studies, we're completely engaged with all levels, starting most importantly with the community, with the government, with the Minister of Health, with the Ministers of Finance of the countries, because we want to make sure the way we're generating our information, we're meeting on a regular basis, and they advise us that we generate information that they think will help influence policy. 2 minutes? I wish I could talk more about this, but I'm on the home stretch. Our study is just completely and utterly community-based. As the researchers, we are just totally behind the scenes. We're working with the political leaders who greet people at the community health campaigns. There's much volunteerism. And here you can just see some pictures around the different sites. I love our linkage to Care Station at one of our community health campaigns. This is one of the doctors that works at the clinic, very inviting. And then we have many interesting questions in terms of migration also, in your talk, just in terms of with our fishing population. So at the end of the day, what is search hopefully going to tell us? Can a population-based ART strategy shut down new HIV infections? And what are the additional gains in terms of maternal child health, TB, education, household earning power? Very importantly, what is the best way to do it, or what are ways to do it, and what do those ways cost? And then secondly, can efficient HIV chronic care models be adapted to established care for other chronic diseases, hypertension and diabetes? And we're studying concomitantly with the HIV care cascade, because we identify people with diabetes and hypertension at our campaigns. We're studying the care cascade for both those diseases in parallel. So this is my second to last slide. So in terms of our enrollment of search, our target was to have the study enrolled by July 1st of 2014, and we're on target for that. We have over 250,000 persons enrolled in search. Our target ascertainment for HIV status is over 80%, and we're hitting about 90% in our communities in terms of status. This is a slide we always show in our team meetings, and I think that, okay, one of the things that struck me when I came to Botswana, your roads are incredible. I mean, I was just like, you can drive around. So this is actually very typical. This is, one of the things when we were out in the field, and so, but I do think, this teamwork sort of reminds me of, we're all a team here together, and so I really want to thank Max for bringing us all together, because there's so many things that we have to share in this journey that we have, and doing really bold